Good morning, everybody. As always, I say this every year, Ellie gives me wonderful titles to talk about, and every year I get my title and I think, what am I going to talk about this year? And I think this is a particularly challenging title because when I first looked at it, I thought about hierarchies of evidence and all sorts of things, and that I kind of thought was a little bit boring the morning after the dinner. And then I thought, well, I'll do a little bit more reflection. And Zita and I at coffee this morning were talking about reflection and how when you first start, when you're quite junior, you don't realise you're reflecting because basically what you do is over coffee you're talking about what happens. And we kind of said at first you just go, oh, wasn't that terrible? Oh, it was terrible. And then you go your separate ways. And as you get a bit more experience, you learn to say, wasn't that terrible? But why was it terrible? What did you contribute? So your reflection changes. So that kind of has helped me a little bit in what I wanted to say. And I'm putting this up, and the first thing I want to say is I want you to all remember I'm a nurse, and I'm very proud to be a nurse, and I'm very proud of what nurses do every single day. Because when I'm going to talk about what's happening in nursing and wound care, some of it feels a bit like this. It's very dismal. And when I started putting the presentation together, I actually stopped halfway through and thought, I can't possibly stand up in front of these people and tell them how bad they are, because that's what it's going to sound like. Everything's terrible. And I feel like we constantly talk about how bad we are. And to illustrate that, I'm going to use a couple of the slides that Alan also used saying how bad we are. But I will change my mind halfway through. So don't be too desperate and gloomy. And I think as nurses, we're quite good at this, accepting that things are really bad, but let's just do it again. Do you all have a thing like this that you think, oh, that's really terrible, but I'll do it again? It's Twiglets for me. I think they're awful, but if you open a packet, I will eat them all. So we know that we do that. And I tried to keep the evidence theme in there. So how many of you, and I know Zena's a Cochrane reviewer, but she knows this. If you read a Cochrane review, I can almost tell you without reading the whole review that it's going to probably say that the evidence is generally of low quality and subject to bias and that more research is needed. Now, for you as clinicians, how helpful is that on a daily basis? Because you have a patient in front of you and you want to determine a treatment, and actually what you want is some guidance. Is that right? So being told, oh, actually we don't really know and there's not enough information, doesn't help you today with your 30-stone patient who's paraplegic in a wheelchair and you need to do an assessment on. You kind of need an answer or some guidance. But I also think that there is some really good evidence and we don't use it. There is a wealth of evidence out there. So, for example, is there anybody in this room who does not know that there's a recommendation that all patients with a lower limb disease should have a Doppler assessment? Or that if you exclude arterial disease, then the gold standard treatment is compression? Is there anybody who doesn't know that? And do you know what? We've known that since Christine Moffat did her work in 1992. So we have known it a long time. But does everybody use that evidence? The answer is no. And is that because they don't believe it? Do you ever read something, do you read a paper, a really nice paper, and think, don't agree with that? Be honest. Yeah. I read the guest paper, the first burden of wound paper that Alan alluded to, and I said, I don't believe that. Don't believe that at all. Because it said things like, a large number of Doppler assessments are done by practice nurses, and this many % are done by GPs. And I said, that's utter rubbish. That's utter rubbish. And some of you are nodding, so you agree with me. And a couple of my colleagues also said this, who were in full-time clinical practice, and they were so cross, they went and audited their local area, and do you know what they found? Exactly the same. So sometimes what we think we know and what actually happens is not true. It's only when you start to really examine the evidence that you do. So this is the burden of wounds, the guest study that Alan alluded to, and I've just taken my parts from a more clinical paper by Vowden and Vowden. So the guest team includes Peter and Kath Vowden, a vascular surgeon and consultant nurse. And what they're basically saying is we treat huge number of wounds, but 30% of them we just call a wound. We haven't even decided, in some cases, to say it's on a leg or an arm. It's just a wound. And some of them it just says open wound. Or leg ulcer. What does that mean? And where there's non-healing or delayed healing, what was really evident is the cost of that patient's care went up That's financial cost. What about the cost to the patients? Are you surprised that if you don't heal a wound, that it costs more? We heard in Gary's workshop yesterday the difference between using dressings of different costs. You may use a product that's more expensive, but the benefit may be a longer term cost saving. But it doesn't always seem that that's happening. And we saw in lower limb and diabetic foot wounds that lots of patients weren't getting ABPI. And even the patients who did get the ABPI, not all of them got compression. More worryingly, a lot of them that didn't get ABPI did get compression, which is quite scary, isn't it? We look at things like, my main area of interest is pressure ulcers. And if patients get a heel ulcer, how many of them get an ABPI? Because the reason they get a pressure ulcer is because of ischemia. And pressure and ischemia together. But we don't think to translate the evidence from leg ulcers into pressure ulcers. Why? Why does that not happen? And what I get told is, well, because they're usually in hospital, and hospital nurses don't do Dopplers. How many of you are acute clinicians? So a small number. Can you do a Doppler? So some, but not all. But you could refer to somebody to do one, couldn't you? And that would make a difference to that patient and to their care. And I think we really need to learn from this study. And once I got over my irritation with it wasn't what my view of what happened was, and started to talk to other people, and it depends on where you are, because this study was done from a database. So you know, if it's depending on notes and documentation, it's a version of the truth, isn't it? Because you know how much you document that you do, and how much you do that you don't document. So anything that's done retrospectively from a database is only going to give you an element of the truth, and we have to have that in mind. But it doesn't mean that it's inaccurate or incorrect. It just means it reflects what people document as their practice. And I do work because I work as an independent consultant, I do work with a lot of commercial companies. And one of the questions that they always say to me is, we've been asked for another RCT. People always say, we go to them with our new product and they say, have you got a randomised controlled trial? Now, do you think that's a reasonable question? If somebody's coming to you with a new product, you want to know what evidence they've got for a product X, Y, or Z, don't you? And it's very expensive to do a randomised controlled trial. Have you appreciated that? For a dressing or something, it might cost around £4 million to do a randomised controlled trial. Now, I'm not saying poor commercial companies, they can't afford £4 million, because if it's needed, but you just need to have that in mind. But there's also, it takes a long time. So Alan mentioned, I don't know when that study started. Where's Alan? I'm looking around. Where are you? When did that study start? Right, about 4 or 5 years ago, to produce the evidence. The Pressure 2 study looking at can we use foam mattresses as much as alternating mattresses was recruiting in 2011, and it closed last November, and it's still not published. Well, when you're talking about mattresses, they've changed a lot in that time. So randomised controlled trials give us one element of evidence, but they don't give us the whole picture. But what you see an awful lot, and I'm really sorry, dressing companies, this is very negative, is dressing company A spends a lot of money. They come to market, they've got the first product, they do a lot of research. And then dressing company B goes, wow, that's a good idea, I'm going to make one of them. I'll make it a slightly different colour, or I'll change something. But what I'll say is, well, it's the same as that one, so I don't need to do research because it's the same as that one. Is that okay? You can look at it from two sides, can't you? You can say, well, actually, if it is exactly the same, apart from it's a different colour or a different size, why wouldn't we? Because morally and ethically, how much time and effort goes into doing a trial? I don't mean the company's time, I mean your time, and the patient's time, and the ethics time, and all the admin that goes around it. So, do we need to do it again? We also have this thing about if it was done in America or Australia, we've got to have one done here. If it's done in acute, we have to have it done in community, or community, we have to have it done in acute. And why? Are their patients significantly different? If it's done in something like critical care, are critical care patients much the same across the world, really? They tend to be. So why do we need to do it in every country? But there's also the perspective of, actually, is that the same product? You need to be really sure if they're saying, well, it's the same as that. I don't need to do any research because mine's the same as that. Check that it is. check what the differentiator is, because we've got that really positive side about let's not waste time and effort, but we've also got the, is it truly the same, or is there something slightly different? And if it is slightly different, you can't use that research. So we need to really think about that evidence and how much we're prepared as clinicians to accept, and how much we'll say, actually, no, that's not quite the same. I want your evidence on how that works. And if we're going to challenge the companies about the evidence, let's look at the evidence that we have. So if I said to any of you, what's your healing rate for your service? Can anybody in this room put their hand up and tell me what the healing rates are for their service? One person. Two. Okay. Isn't that terrible? If you went to McDonald's and asked them what their wastage rate was, do you think they could tell you? For any given day, for any given store, for any particular shift, but we can't. We can't tell you something really important, like the main thing we try to do with our patients is make them better, isn't it? I mean, that's kind of our job, to make people better, but we can't tell them if we do. Do you know your infection rates? No. So we can't even tell people if we harm them. Do you know your amputation rates? Do you know there's a really good map of diversity? So if you go to the Atlas of Diversity on the NHS England website, there are maps of the spread of certain things. And peripheral arterial disease is one of them, obesity is another, and amputation rates is another. So you can go to your locality and see what your amputation rate is and how that compares to the people next to you, to the people over there, to the people down there, to see if you're doing anything the same or different. How many of you measure quality of life for your patients? 2, 3, 4 people? It's quite an important thing, isn't it? There's a lot of talk from the government at the minute about patient-centred care, patients being the focus of care, and we've got to think about what it means to patients. And my final question, which is a really important one, are you all aware that the NHS is actually quite broke? Yes? Have you noticed that in every communication from your organisation? It's about SIPs, save some money somewhere, you know. We have no money, we can't afford this, let's save money. And I regularly have conversations with my family, none of whom are medical, about, do you know what, I can't be doing with all this, let's save some money, because what I think is we should just stop wasting money. And if we didn't waste money, we wouldn't have to save money because we'd actually be in quite good balance. It's the equivalent to saying you've got £100 for the week, and actually what you do is, as you're walking along, you just drop £10 or £20. But what you then try and do is not spend some. You know, you don't have your coffee. Because if you didn't have your coffee, you'd have more money left. Actually, if you pick your £20 up, you'd have a lot more money left, wouldn't you? And I think that's kind of where we are with the NHS. So from the burden of wounds study, and from other things, from other research that's going on, there are so many things that are worrying. We are not assessing patients properly. And it was great to hear Alan talking about the fundamentals of care. This actually, use your eyes, put your hands, you know, your real hands, not lots of gloves, your real hands on patients, not a machine. Check their pulse yourself. You know that Dynamap thing, that Dynamap that does their blood pressure? Doesn't tell you anything about the feel of the pulse at all. We need to put our hands on patients. We actually need to decide what it is we're dealing with, and as nurses, I think we're very scared of saying, this is my diagnosis. We think that's a thing that doctors do. But if we don't know what we're treating, how can we treat it? And we need to set objectives and not be scared of changing those objectives. So my objective is never to heal the wound, because that's quite long term. My objective this week is manage this, get to that point, reduce the wound by, reduce the symptom by. And also we must evaluate the care. We must look back and say, did we make the right choice? And do you know what? I make the wrong choice all the time. If I'm seeing patients, I quite often make the wrong choice. Because it might have been the right choice for the previous patient, but it's not the right choice for this patient. And there'll be one little piece of information I didn't know about that patient, and it might be about something that goes on at home. So, for example, I had a patient who had a black heel, and she was in hospital and we started to get it better, and she went home and we saw her in outpatients, and it just kept coming back. And we checked her footwear, and she got specialist footwear with insoles. There was nothing else she was doing. And I was so frustrated, I decided I was going to do a home visit, and she wasn't expecting me. It was one of those, you know, when something's chewing over, and I was in her locality, and I thought, I'm just going to call and see if she's in. And she answered the door, house slippers. When you stand on the back of your slipper, exactly the shape of the black heel, exactly the shape. But of course, when she came to hospital, she wore the special shoes that we told her that she had to wear. But when she's at home, she doesn't wear them at all, ever. So sometimes we have to look at why we're making mistakes. And importantly, we have to escalate care. And escalating care is something we are really bad at. Have you all heard the phrase, keep and treat? Do you know what that is? That's when you think, I'll just try this dressing, I'll just try this dressing, I'll just try this dressing. Instead of thinking, actually, this isn't getting better, I'm going to refer it to somebody. And it's about, we don't like to admit defeat or failure, but we should refer much more quickly. I also think there's an element of too much choice. So this is the Journal of Wound Care Handbook of Dressings. If you've not seen it, Journal of Wound Care out there, they've probably got some. It's free. It's really good. It tells you about lots of different dressings. My favourite irritation are foam dressings. So in this handbook, there are 34 pages, or if you take the adverts out, 22 pages, just of foam dressings. And if you pick specific brands, one brand has got 18 variations, not sizes, variations. I can't keep up with that. How can you keep up with that? So having too much choice actually means what you do is you use the things you know. That's what happens, isn't it? You stick with what is safe. I kind of hesitate to show this. This was my first ever wound management formula that I wrote in 1992. And basically you've got 8 options. This is what you did, and sadly the first one is Varadays, so that shows how old it was. And I think when you get down to number 3, it says actually refer back to number 2, because we only had 5 dressings. And do you know what? We managed perfectly well. So the minute we overcomplicate things because we try and be so niche, we'll put this little bit of thing there and that little bit of thing there, let's be consistent and we will achieve much better results. And when we talk about evidence, you've all heard of gold standard evidence. Gold standard is compression. What I've started to see coming into the literature is silver standard. And this really winds me up. I read a paper the other day about, it was a TVN, and I'm sorry if you're in the room, doing really, really good work with nursing homes. And what they had concluded was that their nursing home staff were not competent to apply 4-layer bandage. So they developed this silver standard where they basically got a bit of tubey grip and a crepe or something, something that wasn't really very good. It wasn't optimum. So it was given a little bit of compression, but not the right compression. And yesterday, did you not hear all those different sorts of compression you could have that patients could do? And my answer is, if a patient can apply hosiery or a wrap that gives gold standard compression, why can't nursing home staff do that? And to me, that's really worrying that we're starting to think that silver standard is perfectly acceptable. If that was your relative, would you be happy with that? Because I wouldn't. I would be at that home saying, I'm sorry, we're going to do something different here. And they would. Alan mentioned this, and I think, again, this was another challenge to me. Have you all seen Betty's story? It's a very sad story about a very active lady who, she swims and she goes rambling and does all sorts of things, and she bangs a leg on a stile and it basically finishes up. She doesn't leave the house because of a usual catalogue of misdiagnosis and weight and all sorts of things. And the frustrating thing for me was that nobody stood up and went, oh, that's completely wrong. That doesn't happen. Everybody went, oh, yeah, we've got lots of those. And I feel appalled that we accept that litany of poor care is perfectly normal. Perfectly normal. And I think that's terrible when there's an example of what should happen and you see how much better the patient gets. Because for me, this is a typical patient journey, isn't it? The patient gets a wound. Now, we have no control over this. Let's accept we have no control over it. How do you make a patient go to the right place? If a patient has a broken bone, they know to go to A&E, don't they? If you break a limb, that's where you go. If a patient gets a wound, how many of them know about tissue viability services? And they go to whichever one of those is easiest for them. And whichever one of those does any of those things below them, backwards and forwards, upwards, sideways, down, round and round and round in circles, to finish up with one of these things at the bottom. Now, the optimum is that the patient heals. But what we know is that's not the common thing. The most common thing is they don't heal. If they're a diabetic patient, quite commonly, they have an amputation. And sadly, if they've got a black heel that's a pressure ulcer, quite often they die. You know, we've got a real strong correlation between black heels and patients dying. And that's nothing about the care. That's an indication of the failure of the skin relating to terminal illness. But isn't that worrying? If that was a cancer patient and we had this mishmash, nobody would accept it, because cancer services are organised, people know what to go, there are standards, you know you should be seen in this time, but we don't have that, and it's really shocking. And part of it is all this. We see too many people. Everybody is interested in wounds, but nobody takes responsibility. And after all that doom and gloom, I want to move on to something a bit more positive, because I think we're actually starting to change. I think we're starting to challenge some ideas. So some of the things we knew about venous disease and lymphatics, we're starting to understand better that it wasn't that actually, it was this. So we need to start rethinking how we manage things. We're understanding a lot more about fluid clearance and how important that is. We're understanding about lymphatics. We're seeing much greater working between tissue viability service, lymphatic services, vascular teams. We're starting to get a focus on the lower limbs. So on the tissue viability stand, they've got a thing about stand up for your legs, and that's bringing together lots of organisations saying, instead of us all working, doing our own bits, and that's where all the things go wrong, let's all focus and work together. We heard yesterday about, with venous leg ulcers, should we be actually treating the veins, not the ulcer, and then they're going to go away? And if we know what the cause is and manage that, not the symptom, then actually the patient's going to heal and it costs significantly less. But it's just from a different budget, and that's the challenge, is it's from a different budget, and how do we get hold of that money to get it to the patient? Gary talked to us about the cost efficiency ratio, which I loved. I love this idea of dividing your wound surface area reduction in your costs together and being able to say, actually, that costs more than this. And we have got so much technology now. Now, I say this with a big caveat. Technology in the NHS is a nightmare, isn't it? Because our standard electronic patient record systems don't talk to each other. Even if you've got an integrated trust, the community one sometimes doesn't talk to the acute. But there is such huge potential there to use digital technology, both to capture data for us and to trigger interventions and to trigger pathways. Even things like being able to do a point of care diagnostic for that patient's got an infection. That would be amazing, wouldn't it, rather than waiting for a swab. We've also got some really high-level kind of support. So at the minute, I'm working for NHS Improvement on the Stop the Pressure programme, and I know this is about leg ulcers, but it's to show that in wound care, we are starting to pull together something centrally. So what we're saying is, so you all know a little bit about pressure ulcers, I'm guilty, even though you like leg ulcers. How many of you hate safety thermometer day? It's shocking, isn't it? Because we all interpret it differently, and everybody gets beaten up about how many pressure ulcers they've got. We're trying to have some consensus on the definitions and the terminology. We're putting together, at this minute, a national framework for a pressure ulcer curriculum and a competency that will be national for undergraduates and for qualified staff of all disciplines, not just for nurses. We're also putting some work together around doing a national audit. Leading change, adding value is the work of NHS England, and that's where Betty's story came from. Are you all aware of the wound assessment sequin, those of you who work in the community? There is a national sequin about wound assessment. You have a quality measurement. You will have money withheld if you do not meet your wound assessment sequin, and it's a big chunk of money. They've put together a minimum data set for wound assessment. So instead of everybody having a different form, at least now we know you might have a different form. It might be portrait, it might be landscape, but it will at least capture the same information. And they're starting to put together a lower limb pathway. There's another team that sits in the central area, which is also called the Improvement team, not NHS Improvement, the Improvement team. So we call them the Carter team because they're part of Lord Carter's work. They're about to launch a suite of audit documentation, and please don't groan, because it's going to be more paperwork. But if you're not a Carter hospital or a Carter organisation, because there are 23 Carter community organisations, it's not going to hit you yet. So they have to be Carter organisations, but they are trying to get some baseline data. And it's important that we have this baseline, because if we don't know where we're at, we don't know if we've improved. So they're looking at the number of patients receiving wound care or wound care interventions. They're looking at how many were referred, how many healed, all sorts of other things. But they're also looking at what's your organisation got. Because it's all very well to say you didn't refer them to whoever if you haven't got one. You know, in my local area in Hertfordshire, we haven't got a leg ulcer service in West Herts. We've got one in North Herts, but in the West they decided not to commission it. So you can't see you haven't referred them to leg ulcer service when it's not there to refer to. And we're starting to see that care can and should be standardised. We shouldn't be doing this, everybody has their own idea of what it's be like. Patients should get gold standard care. And that we should, as Ellie says constantly, put the patient at the centre of that care. And there is a big load of central jargon at the minute about we shouldn't define care by walls, by buildings, by organisations. So we shouldn't talk about patient can't have that because that hospital doesn't deliver it. It should be about what that patient needs, and the care should be available where the patient needs it. And that's what the STP plans are about, trying to make sure in a bigger area the care is available for the patient. And it shouldn't confine care delivery. It sounds amazing, doesn't it? But I can feel you all going, oh, really, really. And I do think things are changing. I think that we are at a really exciting period in time for wound care. There is so much starting to happen. All this high-profile stuff can only mean that we're going to have to do things better. And it's got to be better for the patient. It's not going to be about saving money, because the best way to save money is to do it better, to be smarter. And my dream is that everything will have a pathway. Now, the diabetic guys, they've really got it right. They already have this as a pathway. It doesn't mean that it happens, but the idea is there and they are working towards it. And I started to try and think about, if I was a specialist, what would I want patients coming to me? And what I'd like is a good referral, a form that actually had the information on. You've all seen, how many GPs are in this room? You've all seen a GP referral form. Patient has a wound. Yeah, I'd like something more. And the ability to send that back and say, unless you give me the details, I'm not seeing this patient. And that when you get a good referral, you should be able to triage your patient. So there should be somebody whose job it is, who knows what they're doing, to say, this is urgent, for whatever reason that might be. But also say, in order to see this patient, we need, because that patient might be your 30 stone or your 45 stone. It could be a bilateral amputee. They could need something special. And we need to see them with this speed. And when they come for their first assessment, it shouldn't depend on who they see. There should be a list of what happens to that patient, exactly as Alan described. We do this in a logical, structured way. This is what the patient gets. And they get that irrespective of who sees them. And that decides where they go. And there's a pathway, there's a flow, and it takes them to further assessment. And it might go for surgery, or it might be local treatment. It certainly always involves education for the patient, their family, for their carers. But very importantly, there are what we call red flags or stop points. You don't just keep doing it. After 2 months, somebody says, is this patient getting any better or not? And you look at why. So sometimes static is brilliant. If you've got a patient who is massively unwell, multiple comorbidities, to prevent them getting any worse is a win. And we have to accept that sometimes static is a positive. What we don't want is deteriorating. And if they're improving, fabulous. But we need to continue and take patients around that flow. But very importantly, this isn't going to happen unless you make it happen. I can stand here and say, oh, Central are doing all these things, isn't it amazing? It's only going to happen if you take on board that change, if you fight for that change at your local level. If you go back to your organisation and say, what are we doing about all this? So it is really, really positive. And Alan left you with that lovely picture of the fish and the lily. And I'm going to leave you with the picture of my latest baby. He's a little monkey. It's the reason I've got an infected finger, because he put his claw right on the side of my nail. But he makes me feel peaceful and in my happy place. Thank you.